Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. My name is Rebecca and I will be facilitating today's webinar. Every time we relapse, I learn more. This webinar is part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. However, we're glad that it will be watched all over the country, and our presenter today is from Queensland. This webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We do want our webinars to be interactive, so please do ask questions via the Q&A function, not the chat function. The questions will be collated and answered by our presenter at the end. Please also be aware that if you need to, leave early or come in late, that all our webinars are on the website and this one will be available shortly. We encourage you to stay to the end of the webinar and complete the exit survey when the QR code appears on the last slide. It'll also be available via email later today. Our presenter has kindly agreed for the slides to be shared, so they will be emailed to you. I'd like to introduce our presenter today, Sam Brookfield. Sam is a postdoctoral research fellow at the University of Queensland School of Public Health after recently completing his PhD research with people attempting recovery from harmful methamphetamine use. Sam is also a registered nurse and has worked in emergency, education, humanitarian contexts, most recently with the International Committee of the Red Cross. His research agenda is aimed towards improving healthcare for marginalised populations through understanding complex experiences of health and illness. Thank you so much, Sam. Welcome to our webinar series.
Good afternoon, everyone. Thanks very much for the opportunity to present to you today. As Rebecca said, I'm Sam Brookfield. I'm a researcher at the UQ School of Public Health. And so today I'm going to be talking to you about how and why people use methamphetamine, some of the reasons, and what are some of the things that shape their trajectories of use. This is based on my PhD research, which was following just a small group of 12 people very intensively over about 6 months, each of whom was experiencing methamphetamine-related harm, and all of whom were engaging with recovery services in one form or another. And so we're looking at what are the significant factors as people move in and out of harmful drug use, manageable drug use, and then also periods of abstinence. And then also, what are those experiences like, and what are the values and the belief systems in play for those individuals going through the trajectory, and also the values implicit in the services they access and sort of the world around them. So for this research, I used ethnography. For anyone unfamiliar with it, in some ways it's a very simple research method. It's based around participant observation. So observation done by me of the participants. The idea being to understand behaviors, you get out into the world and observe people doing them in the real world and participate in that environment. So I used participant observation and also semi-structured interviews. Each participant had 3 interviews at the beginning, middle, and end of the data collection. And it's about this long-term exploration of complex social environments. So if you like, you can think about it as stalking somebody with their permission. It's a form of stalking that's been approved by human research ethics committees. So I would go to people's homes, meet with their families, and then a lot of it was focused around the activities that were related to recovery. So this could include going to doctor's appointments, going to counselling appointments, going to see parole officers, court hearings, helping people move, getting the dog out of the pound, all the different aspects of their lives to try and generate a rich picture of what their lives are like. And I should say as well, the project was supported by a community advisory group, which was put together with the support of QIN, the Queensland Injectors Health Network, which is a really fantastic harm reduction focused service here in Queensland. And so we had a community advisory group made up of some Quinn staff members, peer support workers, and some of their clients and consumers as well. And they were really valuable in terms of guiding me in terms of how to approach the research, some of the issues throughout data collection, and then having input on data analysis and the findings as well. And so why the focus on methamphetamine use specifically? Well, for me, I was focused towards this because it continues to be an escalating health issue in Australia. We use more of it than almost anywhere else on Earth. I think Slovakia overtook us for a while, but we're back on top at the moment. Australasia has the highest rate of amphetamine dependence in the world. There's this pretty significant statistic from Queensland, where between 2009 and 2014, we had a 17-fold increase in hospital presentations that were methamphetamine related. Meanwhile, of the treatments or like the recovery services we have available, something around 90% of people who access those sorts of abstinence-focused treatments will return to their previous pattern of methamphetamine use if that outcome is assessed over the next couple of years. So I think our understanding of the drug use itself is not as good as it could be, and the treatments we have aren't effective, or they require multiple treatment presentations. And I think methamphetamine is interesting as well because it has a significant relationship to occupational use and functional use. It's really linked to our ideas of productivity and people desiring to be productive and manage their lives independently. So I think it's a drug that has a very interesting relationship to our current current culture and the cultural context it's being used in. So I think what we have in place from a theoretical perspective and a practical perspective isn't addressing the issue as effectively as it could be. And so I wanted to try and understand what's the story behind some of these numbers. So if we have a sudden increase in treatment presentations and dependence, what's going on for people before and after they access a service, before and after they present to hospital, and what's that context out in the real world. So to tell you a little bit about the participants, so we had 12 participants who can given pseudonyms here, and they're separated here by their trajectory, which is in sort of general terms. So there were 4 participants who, throughout data collection, did have some long-term abstinence with some intermittent lapses of use. There were 2 participants who moved to controlled use or reduced use. So that was going from once a day or every couple of days to once a week or every couple of weeks. And then there were 3 participants who were using frequently at the start and were still using frequently at the end. They didn't have a big change in their methamphetamine use during the project. We had 1 participant who withdrew about halfway through the project after some data collection, and there were 2 others that withdrew or were lost to follow-up after some initial data collection. Jack and Michael, they were 2 participants who were also experiencing homelessness at the time, so that made it more difficult to stay in touch with them. As we can see, most participants were in their 30s and their 40s. Most were accessing recovery services throughout the project of some kind, and most of them had been using methamphetamine for quite some time. Most participants had been introduced to it as teenagers or young adults and were now in their 30s, late 30s, early 40s, and really wanting to change this aspect of their lives and reduce their use. So I'm going to go through a couple of different aspects of the findings. First, we'll focus on the stories of 3 participants, Jane, Bridget, and Kira, and how they experienced their trajectories of use, and they found different ways of living with harmful drug use, which is an idea we'll keep coming back to. And then we're going to talk a little bit about methamphetamine-related pleasure and what called in one of the publications the cascade of methamphetamine use, and sort of the importance of understanding this aspect to understand trajectories. And then we'll talk more generally about the barrier and enabler factors that shape these trajectories, and then have discussion about what it all means and these concepts of living with harmful drug use that I think can be really useful to inform policies and interventions. So first is Jane. And Jane was 39. She had 4 children. She was living with her partner, Ian, of 1 year. He had 2 children. They'd met through methamphetamine use. They both wanted to stop using at this point. Jane had been to long-term rehabilitation once a couple of years previously, but she was still very engaged with other services. And that really came through in a lot of what she was saying. She was very well-versed in sort of recovery terminology and recovery ideas. During my time with them, Jane and Ian lapsed several times. They described them as lapses. However, Jane would always emphasize how she felt things were getting better. The lapses got shorter, her ability to anticipate triggers became more acute. So here in her final interview, she said, "I think I've grown a lot since the last lapse. Every time we relapse, I learn more. And that's what I take from it. Rather than getting depressed and upset that I'm still using, it's not about having to give up and staying stopped. It's about when you use and what you need to do with the kids and stuff and having that support network. I guess it's not giving you permission to do it, but it doesn't make you feel like you've got so much pressure to stop and be stopped completely." And so I've kind of compared it here to rock climbing, where like you might fall many times, but the fact that you're back at the bottom of the cliff doesn't mean you're starting from scratch. You have what you learned the last time around, and harms may be reduced with those skills. Other participants reported similar things, pointing out how they developed the ability to control how they use or how much they use, and reduce the length of periods when they were using. Meanwhile, I think it's also worth pointing out that the abstinence-only paradigm could sort of overshadow participants' experiences. Like in this quote, you can see that Jane still feels like she needs to qualify what she's saying. She's sort of acknowledging that she doesn't have permission to use, even while explaining the ways that she's steadily gaining more control. And so I think this indicates that when we're evaluating someone's health and well-being, we have to always have a much wider focus than whether someone is just using drugs or not. And we need to recognize the forms of progress people experience in their lives, even in the presence of sometimes frequent drug use. So I think Jane's experiences can support a harm reduction model, even though she was personally oriented towards long-term abstinence. And I think we can see how harm reduction and abstinence can be complementary and integrated and aren't two adversarial approaches to this issue. I think we need to recognize and support progress when it occurs, whatever it looks like. Next, we have Bridget. And so Bridget was 41. She was a single mother of 3. And throughout the time she and I knew one another, Bridget was snorting or injecting methamphetamine most days. One day, I was driving us back from the pound where we just bailed out her dog who had escaped again. And Bridget was talking about an appointment at this drug and alcohol service she had the next day. She was saying she didn't want to go. She was saying, "I'm not looking forward to this, Sam. I don't want to do it." At this point, she didn't see any realistic options for her to seriously control her use, like going to long-term rehab, because who was going to look after her kids if she did that? She also thought that the next day she was going to be facing multiple clinicians, like some kind of an inquisition, and that they might question her ability to look after her children. She was also worried that she would have to speak to one of the psychiatrists there, who always wanted to try and dig stuff up and get to the traumatic roots of Bridget's drug use, which was a conversation she didn't feel ready to have, especially not tomorrow morning on what would have been day 6 of frequent methamphetamine use. I came back the next morning. We drove Bridget to the appointment, and we're sitting in the waiting room. She's playing a game on her phone, and she started explaining what a complicated role methamphetamine plays in her life. She said, "It's funny, even though I've got this problem, I'm actually quite happy within myself at the moment and the way things are going with regards to my relationship to my kids and home and stuff. It's better than it's been in a long time. There are certain things about it, meaning drug use, that aren't bad, that actually I just get on better with them sometimes when I'm in that state. And we'll have deep conversations about school and friends and whatever." And then with her eldest daughter, she said, "We've never got on better than we are at the moment, which is full on. We've had lots of ups and downs." I said, "Why do you think that is at the moment?" He said, "Because I'm not depressed. I don't know. Our relationship seems to be improving. Yeah, I can't say there's nothing good about it." They called us through into the clinic, and she was very relieved to learn she was only speaking to the clinical nurse who she'd known for a long time. They had a long conversation, and they arranged for her to attend for the next few days for an outpatient detox process, which worked well for her. So what I saw here was how important it is to communicate clearly about what we're offering to people who are using drugs in order to get them in the door, to reduce fear of stigmatization, and how much more effective for Bridget the nurse's approach was versus the psychiatrist. Also, when Bridget thought about this service, it had many different faces for her, and I think that's easy to forget as clinicians. It appeared arbitrary to her which person she saw, and they meant really different things for her. Also, Bridget could have different faces at different times as well, speaking to me about drug use a bit differently to how she spoke to the clinical nurse. And I wouldn't say this is her being dishonest. I think she's just aware that only certain interpretations of drug use would be accepted in the clinic. And so while there, she spoke in a way that agreed with them. And I think that's an important thing to bear in mind during clinical conversations, these subtle ways that we can restrict what clients feel comfortable disclosing by implying what we will think is acceptable. In the final interview with Bridget, it was a warm spring afternoon. She'd been doing housework all day. The house was full of the smell of mown grass from the freshly cut lawn that she'd organized. At this point, she had a partner of several months, and on that day, she was feeling positive about her life. And once again, she emphasized the positive changes she'd experienced and how she'd continued to live closer to the kind of life she wanted despite ongoing drug use. She said, "George and I have been together almost 7 months. Feels like 7 years. So much shit has happened in that 7 months. Unbelievable, good and bad. I've grown here. I have to say I've learned to be more tolerant, more loving, how to communicate. He's taught me a lot just by having him by my side. Today, I've had a bit more than I usually do, if not every day, every other day. Probably I've cut down. I was using it there 4 points a day. I've got it down to about 2. It was time to pull up a bit. But, we've paid for and booked our wedding. Things are happening outside of drug use that in my life that I'm really happy about. I'll say I'm much happier. Probably the happiest I've ever been is now." So Bridget's still referring to a process of growth in the presence of drug use, including growth in her relationships, her personal life, and her happiness, which she has intended while she's attended at different points to reduce her drug use, her priorities were towards her children and her partner and controlling the harms, rather than taking steps towards complete abstinence, which from her perspective would have required a massive disruption to her living situation and would also have caused the loss of her only social support network, because all of her close friends were also using drugs, and she would have lost all of that as well. So I think Bridget provides another interesting example of someone living with harmful drug use. She credits using methamphetamine with making her less depressed, enabling her to communicate better. But she still discusses these things within a wider cultural narrative. She's talking about the expectations of motherhood and abstinence-based recovery. So I think Bridget is sort of simultaneously reinforcing and subverting these narratives. She acknowledges the authority of this wider narrative that requires abstinence, but maintains her own experience as an exception. Leaving aside methamphetamine's actual effect on her parenting, whatever it might have been, Bridget's description disrupts the norms that are implicit in public health and in abstinence-only drug treatment. Bridget was observed, she was interacting with her daughters, prioritizing their well-being and health despite her ongoing drug use. Both of these things could happen at the same time. I remember one evening she became really angry towards her partner when she caught him smoking a cigarette in the house where her daughter could just smell the smoke. For Bridget, frequent or harmful methamphetamine use occurred alongside the management and pursuit of these other priorities of maintaining what she called normality at home. And I think we need to be aware of these ways of living when designing our services. And finally, Kira, she was also in her late 30s, a single mother of 4. Her family had broken down about 4 years previously when her husband was convicted of assaulting one of their daughter's friends. She was using methamphetamine 3 or 4 times a week. And she told me how she'd been to rehab twice, but both times had checked herself out in order to manage issues going on with her teenage son. She said she would go to rehab again, but everyone around her, like her children and her parents, needed so much from her all the time. She felt like the daily chaos of life was so all-consuming that she had no time to focus on recovery and think about how she could extricate herself from this very complex network of relationships and commitments. As she said, "I don't know how to get myself out of, I don't even know what I'm in." Throughout this period, Kira rejected the idea of residential rehabilitation, again, because she viewed it as an interruption to her process of negotiating with child safety. as she was trying to get custody of her youngest daughter back. In her second interview, she talked about the kind of placement she would consider, where she said, if I could take the bub and that and have them in that kind of recovery, however long I'm there for, if I could still have those little things, but being kind of restricted and then limited to when I can come out to spend that time, just have only a day on the weekend with them when I was so close to more than that right now. Meanwhile, by the end of the project, Kira had gone from supervised visitation with her youngest daughter to regaining custody, and she'd found her own private accommodation where she was living with that daughter and her teenage son. In her final interview, Kira reflected on the previous few months and emphasized her experiences of growth, change, and progress, despite ongoing drug use. She said, even with a little bit of using now, I might high-five myself at the end of the day to get to where I am. It's been a long time coming. It's just felt like forever. I can feel that I'm definitely in a better place in my head. I've wanted these kids back and I'm going to get them back. I asked, what is it about, what's happened in the last 6 months that makes you want to high-five yourself? She said, the relationship building that I've had to do. Even though I've had a good relationship with Mum, I've still had to build so much with her since the last few years. I've had to show, I don't know, I guess sometimes I didn't show the respect I probably should have shown. It's made me grow a little bit in myself too, even if it is only a little bit. I never saw my small steps. For a good year at the beginning, nothing mattered. It didn't matter if I took 10 steps forward, it didn't show that I took one. Now it's like I can see these steps and each one is getting a bit bigger each time. And the reward is definitely worth taking these steps forward. So while reflecting on the previous few months, Kira again highlights progress in terms of individual factors, such as her mental state and relationships, and then also more structural issues like her living situation and her relationship with child safety. Without maintaining abstinence, Kira's trajectory has still been towards a stronger position from which to work on her recovery. She viewed her own personal health and recovery as secondary to regaining custody of her children. Meanwhile, it was also noticeable that as she gained more responsibility for her children and they came back into her life, this actually supported her to fulfill her other goals, like getting private accommodation, building more positive relationships, and then her drug use was having less impact on her life and she was using less as this responsibility came back. So what we can take from this is that it seemed impossible for Kira to get to a place where she could launch herself out of the web of relationships she was in by doing something like accessing a long-term rehabilitation, partly because what services she was in contact with either didn't address her drug use, like child safety, or were not active enough to successfully engage her. So I think Kira is another example of where active, persistent, harm reduction-based outreach could make a really big difference, where the service is brought to her in a way that isn't focused on abstinence only. Instead, for a lot of the projects, she continued to use, she continued to feel trapped, and then figure out on her own how to work towards her own goals. So the other big part of this I wanted to talk about was pleasure and the pleasure of drug use and what it means and what it's like. I think it's not talked about that much. We tend to focus, and often rightly so, on the pain that people experience when they're using drugs in a harmful way. And it's kind of baked into the way that we talk about it when we say drug use, implying people are using drugs like a tool. And in many ways they are, but we don't talk the same way usually about people using food or using art or using other things that give us pleasure. So I think understanding trajectories of methamphetamine use and recovery, they require an in-depth understanding of the experience of use itself, and that includes the pleasures people get from it. And I think getting a better understanding of this pleasure can help us talk about it in a productive way. And otherwise, I think the pleasures of drug use can be used to sort of dismiss it as simply a hedonistic or escapist activity that people should simply choose not to do. But as one of the participants, Claire, said, everyone has a good reason for doing what they're doing. And so it's important we try to understand what those good reasons are. Now, obviously, pleasure is never going to be just one thing. And so looking at the participants' descriptions and behaviors, we identified 4 key domains of methamphetamine-related pleasure, which can help us understand what to focus on when reducing harm, which are these 4 here. So we've just got some quotes for each of them. So the first one was escaping via the rush. There was the initial rush of drug use and the way that would enable people to escape the way they were feeling at that moment. Claire relates it to childbirth. She said, when you're like, it's done. And it's like the baby is now on your chest. It's just like love, like the grand finale of life. Ian said that to start with, it's just the rush. It makes you feel 10 foot tall and bulletproof, makes you feel really good, like you can do anything. So I think already here we can see that these aren't just this isn't just an abstract experience of pleasure. These are feelings of confidence, of freedom, of peace. These are of things that maybe for these participants, there wasn't any other way for these to feel these emotions. Outside of the rush, there was the social aspect, the ability to make social connections, to experience intimacy as well. As Bridget says, my personality changes completely, sometimes a bit too much. All of a sudden, I'm happy, I've got something to talk about and plenty of energy. I feel powerful, feel confident, happy, I guess. That's just the thing, like chasing happiness. I've never truly been particularly happy for long periods of time. And I suppose a depression that comes into it. So for a lot of the participants, a lot of their social connections were built around drug use, happened in the context of drug use. But also they really struggle to have social relationships without drug use being a part of it. They would feel lonely and isolated. And so for many participants, there was a component of self-medication as well. As Simon says, that's probably the core of my problem, is that I don't have many activities. If I sit at home by myself, I start to feel lonely. Eventually I get depressed about that because I don't want to end up alone. And then that tends to be my trigger in using. So my trigger is not money, which it is for quite a few people. It's to get away from that feeling. And then finally, there was the interesting one, which I think is very deeply related to stimulant use specifically, which is desiring productivity. So participants would have an awareness that they feel like they should be productive, they should be doing things, or they're very alone in their responsibilities in terms of childcare and looking after the house. And so methamphetamine would assist them with that, or give them the feeling that it's helping them with that. Kim would say the higher you get on it is really unique. It opens up your mind to learning new things. It opens your mind up to not a new dimension, but a new realm. You focus more on what you're interested in learning, and your mind opens up to learning new things. And Jack says, I know what I'm doing. I know I shouldn't do it, but I'm going to. And then I just do it. And then I think everything is good again. I said, you think what? He said, then you think everything is good again. I'll do this, I'll do that. It just never happens. I'll get a job and then it's gone again. You're just on the downer again. So importantly, all these different aspects of methamphetamine-related pleasure were woven together in participants' experiences. In the paper, we say these cascade together to produce an episode of use. The desire for self-medication and the desire to escape, the desire for productivity, the desire for social connection. And I think the real takeaway is that these are all fundamental human needs that everyone has: the relief of pain, social connection, having a feeling of purpose. It's not hard to understand why socially isolated people might do something that gives the same elation as childbirth for only $20. In addition to these bodily pleasures, there was cognitive, emotional pleasures of conforming to social standards, of engaging in relationships, of being able to imagine and plan better futures, and of being enabled to perform important tasks like manage finances, prepare food for their family, clean the house, or generate income. So rather than simply a hedonistic or escapist practice, some participants were using the pleasures of methamphetamine to enable participation in multiple virtues that are generally expected of modern neoliberal citizens, like productivity and independent self-management, looking after their own lives on their own. It briefly enabled them to be who they felt like they should be. None of the participants denied the risks or harms related to their drug use, but these were weighed against the privations of their material realities as unsupported single parents or being unemployed without meaningful social connections. Methamphetamine enabled them to derive potent sensations of meaning and purpose from undertaking otherwise burdensome or boring tasks. So their functional behaviors and maladaptive behaviors were tangled together in this one value system. You have the pharmacologically induced pleasure of methamphetamine, which was still shaped by the cultural and economic settings in which the participants were using it. If we expect everyone to be productive, to be independent, and to look after themselves, then I think it shouldn't be surprising if there's a big increase in use of the drug that can either facilitate that or facilitate the feeling of that. As we said, there were about 3 different trajectories for the participants across the 6 months. 4 had prolonged periods of abstinence, 2 reduced their use to more infrequently use episodes of use, and 3 continued to use throughout that period. And so now I'm just going to go through what some of the factors were in general for the group that seemed to support these trajectories. So for the participants that had long-term abstinence, which was Jane, Ian, Simon, and Stephen, one of the big factors for them were the responsibilities they had, either towards their children, towards employment, and they had realistic goals. So I think significantly quite a few of these factors could be barriers or enablers to recovery, depending on the specific context and the specific individual. For some people, these responsibilities could exacerbate their poor mental health, cause them to spiral in the other direction. But for these participants, it seemed to assist an upward spiral of giving them reasons to remain abstinent. Having access to work and having access to enjoyable work with a social contact made a big difference as well. For one of the participants, Simon, he had a form of work which he made quite a lot of money at, but he was very isolated doing it. And he ended up moving from that to working as a driver in public transport. And it was a real shift from his previous context, but he had more colleagues that he saw every day, and he enjoyed his workplace a lot more. And so by the end of the project, for the length of time he'd been in that position, he hadn't used it all. For these participants, you could really see a cumulative effect of multiple engagements with services, particularly for Jane, who had developed a lot of recovery skills over time. And so I think for these participants, you saw more insight, what you might call insight into their own behavior. They were able to explain themselves to themselves more and anticipate their behavior in the future, anticipate triggers, and make plans for their recovery. They clearly had a more destigmatized attitude to their own lapses as well, the way they described them. They were, as Jane said in that quote before, to sort of not give themselves such a hard time about their use and to sort of keep moving forward, keep moving towards their goals. Supportive families and partners were a big role here as well. Obviously, Jane and Ian, who were a couple, they were supporting each other as they attempted long-term abstinence. Stephen, he was in his 30s and he had a very supportive family that he could sort of live with. So by them providing that accommodation, that sort of reduced a lot of his harms and put him in a much better position. And there was just a real change in priorities for all of these participants. They were very explicit about the shifts in what it was they wanted out of life. And just some examples, Ian says, our priorities have changed. It's not the main priority in our life anymore. It's dropped so far down the ladder now. And this is the same quote as Jane from before, saying, every time I relapse, I learn more. And I'm not being so hard on myself every time we do it. And Simon said, I'm in a strong position right now. I think that if I have contact with friends that use, it's something I need to be wary of. But like if I saw someone now and they had stuff I wouldn't use, but I'm not going to put myself in that position because right now I'm strong enough I wouldn't. But I'm going to keep going to see my counsellor because there's still some issues to resolve with me. And just because I'm strong now, it's not always going to be like that. For Carl and Kim, who had significant changes in their use, important factors for them were, again, access to work. For Carl, he was able to work Monday to Friday, which he was able to use as a sufficient incentive to not use during the week. Support from partners again. Kim's partner did also have issues with drug use, but was actually going through a drug court process throughout data collection, which worked really well for him. And so he had long-term abstinence and was really supporting her with hers. There were some external incentives, especially for Kim, that were a big motivator here. And this is a tricky one because this is another one of the things that can overload people and cause them and sort of exacerbate their issues more than helping anything. But for Kim, she was very motivated by the process she was going through with child safety as well, because she had a one-year-old daughter. She only had a few months left in order to get access to her again. And so she had some court-ordered treatment through that as well. And they would just also talk about increasing dissatisfaction with life, kind of like how the other guys had a change in their priorities that was sort of becoming more acute for these two as well. And one of the barriers really was social isolation. Both of these participants didn't really have close social contacts, either who did or didn't use substances. So that was something that kind of got them into a sort of a manageable pattern where the harms weren't too severe. And so they tended to sort of stay there rather than moving to total abstinence, which they maintained was their goal. As Carl says, I hate needing something that I don't want to need, having to feel like I don't have control over my own behavior. That's one of the things I hate the most, feeling like I'm not moving on, ending up back in the same spot every few months. Kim says, I don't want this life. I want a straight and narrow life, as she said. I want my daughter back. One time I asked, why you accessed recovery services on that particular day? And she said, well, it was for court. It was really for court. I didn't want to go back inside again for the 9th time, which it would have been for her. So I did it for court. I have to do this for myself and for my daughter. And then finally, there were for Claire, Kira, and Bridget, who only had minor or no changes in their use. They were using fairly frequently throughout the project. So importantly for them, there was no change in their external circumstances. There was nothing to really change their incentives for use. I think importantly, these three were all fairly socially isolated single mothers, and they had significant life stresses. They had caring responsibilities they really struggled with. They had financial insecurity and insecure accommodation as well. I think they all had to, well, Claire and Kira both had to move at least once during data collection. So again, interestingly, some of these things that were negative stresses for them were positive protective factors for some of the other participants. They all had constant access to drug use, either in their home, being dealt out of their home, or just being very frequently offered to them. There was more internalized stigma, I think, based on some of their statements and some of their answers to questions in the interviews. And I think for them, it was more entwined with their social identity. And again, it's very embedded in their social context. This is very, very difficult for them to imagine a version of themselves that didn't engage in this. And polysubstance use was a little bit more common for these guys as well. For Kira, she was using cannabis almost daily as well, which she said at one point she felt like had a bigger impact on her than the methamphetamine. And Bridget had a history of opioid substance use. She was on opioid substitution therapy still, and was using some benzodiazepines as well during the project, which was sort of, I think, holding her back from being able to find a way to make some of the changes she wanted to make. This is something Bridget said. She's talking here about 5 milligrams of Valium, which was going to be the prescription for the outpatient withdrawal program. She said, my mindset is not where it should be. It's not like it was. The intention was there. But like I said, 5 Valium a day is just, I said, where is your mindset? She said, I want more, because for the last 6 months, that's how I've coped with my life. Suddenly you think 5 Valium is going to change that? You think it's going to make, now I can cope with doing all the housework and cope with the pressure of caring for my son. I've got to put in a much lower payment, meaning Centrelink payment. We can barely buy food now. Little stresses have arisen lately, financially especially, and I'm not coping well with that either. I worry a lot. I'm spending money I shouldn't be. I can't answer that question properly right now. So there's lots and lots of things compounding to keep these participants where they were. So one of the big ideas coming out of these stories, as I've mentioned before, is this concept of living with harmful drug use, which is based on language which is used for other long-term health issues. There's been a growing focus on chronic disease or chronic illness treatment models as an effective option for managing drug use over the long term, as in rather than only providing acute episodic care. And so there's the important and ongoing debate of whether harmful drug use meets the clinical criteria for a chronic disease. But this framework was implicit in how the participants discussed their experiences. It was language that they used to sort of help them guide themselves through this process. So I think living with harmful drug use can describe this experience of long-term drug use combined with growth and change. The things like heart disease, diabetes, cancer, and even things like HIV now, they're conditions that people are increasingly described as living with rather than suffering from. And so it refocuses management towards how to have the most fulfilling life in the presence of a health condition. And as Jane described, working towards the safest way she could live with methamphetamine use supported her in reducing her use overall. And there's this analogous concept within mental health recovery, rather than addiction, of health in illness, where recovery exists always in the context of some kind of ongoing symptoms. Other models that have been effective with other chronic health issues could be applied more to drug use. Laudette here argues for the application of quality of life models to drug use, which can address many aspects of people's lives that aren't incorporated into addiction symptom measurement. And these quality of life measures could assist us to capture these complex landscapes of well-being that the participants described. If abstinence is our only goal, or if it's a necessary criteria for accessing services, then we're going to exclude the very common cyclical change that many people who use drugs undergo when they're attempting recovery. And it also excludes the significant and long-term and complex work that people do to improve their lives in order to prepare to enter treatment or to make multiple attempts at recovery. For the guys in this study, recovery began with a whole range of different mental and physical preparations before they could attempt long-term abstinence. They did things like changing their living conditions or changing their attitudes toward drug use. And these were all part of how they were living with drug use before they were able to enter this more widely accepted sort of narrative of being someone in recovery. And so I think people using methamphetamine could benefit from health services that support them in living with their drug use in the same way, with the same degree of individualized, demoralized, and strengths-based care that we provide to people living with diabetes, heart disease, or cancer. Participants invoked a lot of different values when discussing their drug use. They valued family, normality, stability, but also sometimes adventure, a desire to sort of beat the system, to reject forms of life that they found restrictive or inauthentic. Sometimes the way they valued family and friends would be a barrier to attempting long-term abstinence. And they would acknowledge the ways that they would sort of deviate from sort of the widespread morality that's built up around our norms of health. So this produced multiple goals in recovery, and both Kira and Bridget wanted to reduce their drug use, but they weren't going to go into long-term rehab because of its impact on their children, because they were able to support their families while using. And so I think we need to recognize the fact that some people will continue using drugs, and that cannot disqualify them from receiving help. These different perspectives on health and recovery have been recognized previously in the literature addressing this idea of counterpublic health, which argues for the recognition of groups within the monolithic general public that have different values and priorities and capacities. Counterpublic health, this idea, it draws attention to how health is constructed in relation to a sort of homogenized and idealized public, while in reality, that will always include multiple different socially marginalized groups whose norms and values may construct health and well-being differently. People for whom drug use and even harmful drug use might be a part of life or be seen as part of life. So a real application of counterpublic health, therefore, would entail this kind of value pluralism, where public health decisions recognize the existence of multiple, potentially conflicting value systems within the population. Bridget's goal, for example, was not abstinence, but reducing her drug use. And so while she's not a sort of moderate, risk-averse participant in our sort of modern health culture, she was still living a life that aligned with her own set of values. And we need different public health interventions for Bridget as compared to someone who prioritizes sobriety. These different interventions will be based on a fundamental acknowledgement and validation of Bridget's perspective and values, rather than a uncritical adherence to more predefined ideas of health and of healthy and normal behavior. So to summarize, the main barriers to recovery or to harm reduction were having a social identity more entwined with drug use, having these multiple life stressors around finances, around family, around accommodation, and having constant access or exposure to drug use. The main enablers to recovery and harm reduction were having responsibilities, but having meaningful and manageable responsibilities, having had multiple service engagements over time, and having a destigmatized attitude to drug use within themselves and having that reinforced by people around them. People found multiple complex ways of living with harmful drug use, similar to how people live with other long-term health issues, that was often not validated by the services they engaged with. And we have to ensure that services are able to support people to navigate whatever kind of change or progress is most meaningful to them. The mostly abstinence-focused programs were based on a value system that at times conflicted with the values the participants held. Developing services to support people through their own trajectories need to acknowledge these different values. And the public is talked about in public health, that the public that is talked about in public health is diverse and dynamic, and a single set of values can't be enforced across the whole population. And if we try, our interventions will have less effect. And finally, there were multiple forms of pleasure people derive from methamphetamine, and these pleasures meet deep and universal human needs for meaning, purpose, empowerment, social connection, intimacy, and hope for the future. Rather than just to escape from life, people used methamphetamine in order to be productive and fulfill the social expectations placed upon them as parents and as independent individuals able to manage their lives without much social or state support. People used methamphetamine the same way flowers will grow towards the sun. To help people move away from harmful methamphetamine use, rather than try to fix something within the individual, I'd say we need to focus on giving them different and brighter sources of light and enriching the social, cultural, and structural ecosystem in which they are embedded. One last thing. These findings have led to several academic publications. What I've gone through today is not all of the findings. We also have a whole paper about the role of normality in their recovery and how they experience their own agency, their ability to make choices around drug use. And there should be a paper coming out later this year that puts all of these together into a model that I'm calling extended recovery. So do get in touch if you're interested through any of these. You know, I'll give a PDF to anyone. And whilst these academic publications are great, it would also be great to find other applications for them. At the moment, I'm looking for opportunities to translate these stories into potentially other forms of education or training, like aimed around reducing stigma. So if anyone knows of anything happening in that area or is needing some consumer or client stories to support that kind of project, do feel free to get in touch. The participants were so generous with their time and their privacy that I'm really keen to maximize the potential impact of their stories. And so to finish, I just want to acknowledge the contributions of all the research participants who gave so much time and energy to this project, the amazing support of my thesis advisors, and then to the nurses that did the recruitment for me, and then once again to Quinn for their support with the community advisory group. And that's it. Thank you very much.
Thank you so much, Sam. I do have a number of questions for you, so hopefully we can get through at least most of them. First one, were any of the participants of called ethnicity? And just, you know, someone observed that the names used were quite Anglo and not sure if it's representative of the participants. If there were people of different cultural backgrounds, did you notice any quantitative or qualitative observations?
The participants were mostly, or pretty much all of Anglo-Australian descent. There was one participant who had come over from Vietnam as a child, but there was no one of a linguistically diverse background. There weren't any significant aspects related to that really came through in the analysis. There were more commonalities than differences, I would say.
Thank you very much. Next question. Do you believe that Bridget, Kira and the other client feel that they have functional meth addiction, meaning that their psychosocial experiences are better? And I'm not sure whether this needs to be clarified by the person who asked.
I think for Bridget, she felt that her methamphetamine use was functional for certain periods, and that sometimes it became non-functional, and her goal was to return to the functional form of use. I think several of the participants were in this kind of interesting area where they didn't like the way they were using methamphetamine. They wanted to change it, but didn't really feel like they could make a change to complete abstinence. So we're finding these ways of trying to find a middle ground for themselves of, well, I don't feel like I can make this change completely. How do I make this a bit better for myself and still progress towards these other goals? So I don't think they would have described it as functional use, but they felt like it was a use they couldn't change, so they were sort of functioning around it. Yeah.
Thank you. Next question. I am a gambling help counsellor and several of my clients have a relationship with methamphetamine use. Did you screen your participants for other numbing distraction habits such as gambling, shopping, pornography, etc.?
Well, we didn't have a formal screening tool, but we did have very wide-ranging conversations about people's life histories and other forms of substance use and other issues they might have. There was one participant who had a real problem with gambling as well. Gambling and methamphetamine had sort of entered his life at the same time, and were very bound up together as well. I think there's another very interesting relationship there. Outside of gambling, there was Kira, who was using cannabis very, very frequently. But outside of that, for a lot of them, other substance use wasn't that common. Even including alcohol, there wasn't much alcohol use among the group either. So so I think for a lot of them, methamphetamine had sort of come to dominate.
Thank you. Did you notice a connection between chronic meth use and trauma?
Yes, definitely. I think there's I think most of the participants referred to various traumatic incidents in their past or in their childhood. And I think it's fairly well established that harmful forms of drug use and trauma have a sort of symbiotic and interactive relationship. So for a lot of them, there were traumatic experiences that made them more vulnerable to engaging in harmful forms of use. And then as they'd progressed through their life, the use itself had been traumatic for them at times and had exposed them to other forms of traumas, which predisposed them to return to harmful forms of use. And there's that sort of vicious cycle. But yes, I think it was pretty much across the board. They had some form of traumatic experience prior to starting their drug use that they refer to as they think playing a role. It was based on their own interpretation of their stories. And then they also all had recent experiences around things like incarceration or abusive relationships that were reinforcing these behaviors over time.
Thank you. Next question. I am curious, what practice framework do you use in your work?
Practice framework, as in, is this referring to like a clinical practice framework? Or?
Yeah, and the person who asked the question might need to type back to me and we'll go back to that one.
Okay.
Thank you. A question in relation to Bridget. Does she have a mental disorder? And, you know, do you think or does meth help her deal with or suppress her negative thoughts or negative self-talk?
Yeah, I think methamphetamine definitely was playing a role in managing her mental health from her perspective. Again, you know, there's all these complex ways in which methamphetamine use can manage and exacerbate mental health symptoms like anxiety and depression. But I think that the pattern she was in was that it was her way to manage it and her way to get through the day and do what she felt like she needed to do. She didn't have as far as I was aware, I didn't have access to people's medical records and things. But as far as I was aware, she didn't have a diagnosis of a mental health condition beyond maybe anxiety and depression. But I know she had some admissions to hospital for what I'm fairly sure would have been like drug-induced psychosis. But wasn't on medication ongoing for that or anything like that. So. I think relieving anxiety and depression was a common thing the drug was used for, as many drugs are. Thank
you. And just following up with that question about what practice framework do you use in your work, just some further information. So a theoretical or clinical framework that guides your clinical work, values, etc.
Yeah, well, I think for this research project, coming from a research perspective, I had a couple of different theoretical frameworks that were guiding it. I take the frameworks I refer to as a relational approach and a critical interactionist approach. And what I would sort of boil that down to is not approaching something like harmful drug use as a problem that's occurring within an individual and as a question of addressing that individual's psychology, but as a process that emerges out of relationships and out of processes. So it's the relationship between individual, family, friends, cultural environment, economic environment, all these different things interacting allow harmful drug use to emerge, but also allow recovery to emerge. So that's sort of how I view, and there's a need to sort of critique the common assumptions or the standard way of approaching these things. So not just assuming that, well, methamphetamine is an addictive substance, so people take it and get addicted and that's that, but thinking about why this is happening now, why these patterns of behavior emerge and how it's different for different people. So yeah, a relational and critical interactionist approach is the theoretical label I would use, I guess.
Thank you. Last question, and then I'm just going to share some comments with you. So the last question is, why do you think methamphetamine use is so high in Australia?
Good question. I think there's a lot of different reasons. From my reading of the evidence, there'd be big sort of structural reasons for why the supply of it increased to Australia over other forms of like the opiates and heroin over the last sort of 20 years. But I think my personal sort of pet theory that I think comes out of this data is that there's cultural reasons for it as well, which is that it helps people deal with what people are dealing with at the moment. It enables to be these, or makes people feel like they're able to be these independent, self-sufficient, sort of atomized individuals. So when people don't have a really sort of strong social network that they're embedded into, and things become unmanageable for them, methamphetamine can enable them to manage it, and also gives them a feeling of meaning and purpose. People will use methamphetamine for work a lot if their job is very boring and unrewarding or even difficult to do. Methamphetamine, it gets people through the day a lot of the time. So I think that's why it's found a very big audience, because I think more and more people are finding that difficult. Thank you.
Okay, just some comments and feedback. What a great study. Loved hearing the end result. I am curious about the responses to some of these questions, or how the participants would have reflected on their drug use when they were coming down or had ran out of money to use substances. As someone with lived experience, I know how positive I was about my drug use when I was using or high, but when I was coming down, there wouldn't have been many, if any, benefits.
Mm.
Someone else wrote, great presentation, very interesting. Another one, thanks, Samuel, fascinating presentation. Although nothing particularly surprising in the findings, it's good to see research reflecting the realities of drug use. Lee has written, thank you, Sam. This is such meaningful and humanising research and has given a lot of food for thought about recovery for clinical practice. And finally, a message here from Karen and Fiona from the Newcastle Stimulant Treatment Program. Thank you. This is an excellent presentation to address stigma, a major barrier to healthcare for our client group. I'm just aware of the time, Sam, and there is more questions that have come in, and other great feedback. So thank you so much for your time. Thank you for sharing your PowerPoints. Thank you for sharing your email address so people can make contact with you. Thanks again, and thank you everyone for joining us today. See you later.
No worries. Thank you.